Welcome all. It's very exciting to be here. Today we'll discuss and learn together about basics of echocardiography. We will take you through ultrasound physics, acquiring basic views of echocardiography, identifying pathology from basic views, and a simulated time at the end. And we have three speakers today. Mr. Ramesh Khadka, a sonologist with a special interest in transcranial Doppler from California. Dr. Mustafa Hassanin, consultant in emergency medicine with a special interest in POCUS from Leicester, UK. Dr. Surendra Bahadur Mathur, assistant professor of pediatrics from New Delhi, India. And that's me, a registrar from emergency medicine, UK. So some ground rules for the webinar today. Please keep your mic in mute and turn off your videos, especially if you do not want to be recorded. Please type any queries that may arise in chat window. I'll try to answer them if I can, and if not, then we'll be forwarding the questions to the specific speaker, and the compiled answers will be posted in the ER Sonar group. This webinar is being recorded and will be available for free. Please subscribe to our YouTube channel and recommend it to your friends and colleagues. The first topic for the day, ultrasound physics by Mr. Ramesh Khadka, sonologist with a special interest in transcranial Doppler, California.
Hi guys, I'm Ramesh from California. Today I'm going to talk about temporal resolution and axial resolution in ultrasound. Hi, let's begin with the temporal and axial resolution in ultrasound. What is sound? Sound is the form of energy. Is it kind of energy is travel through medium? Especially there are different sound. If the sound wave is below than 20 Hz, it's called infrasound. Again, if the sound wave is below than 20 Hz, it's called infrasound. The human hearing sound range is 20 Hz to 20 kHz. That means below the human hearing sound range is called infrasound. Above the human hearing sound range is called ultrasound. The sound wave is more than 20 kHz is called ultrasound. There is some speed of the sound in different materials. In air, it travels 330 meters per second. The same way, water 1480 meters per second, bone 3500 meters per second, tendon 1700 meters per second, fat 1450 meters per second, and the soft tissue average is 1540 meters per second, lungs 500 meters per second. But in ultrasound machine, it uses 1540 meters per second because our body is mixed with water, tendon, bones, fat, air. So the average speed of ultrasound in our body is 1540 meters per second. The ultrasound machine knows only one speed, that is 1540 meters per second. Let's talk about resolution. Today's our main topic is axial and temporal resolution. What is resolution? In simple way, it's one sentence. it is the quality of image or how clear it is. In ultrasound, it is the ability to create the accurate image by machine. Resolution is the important thing in the ultrasound because better the resolution, more the study will be diagnostic. Because as a sonographer, we guys are sonographer, we trust in whatever we see in display monitor. Why resolution is important in ultrasound? In simple way, in one word, it helps to better image quality, and image is going to be more clear quality image. In the ultrasound language, it gonna call diagnostic image. Let's talk about the resolution. Beam wise, there are two resolution, that is axial resolution and other is lateral resolution. Axial resolution. What is axial resolution? Axial means axis or same axis. It is the ability of system. We're not talking about the external force, we're talking about the machine. Inside the machine is a system of the machine, because the ultrasound beam, we assume it travels 1540 meter per second. Is the ability of the system or display quality of two different structure that is very close to each other, and the structure gonna be same axis and the parallel to each other. The axial resolution is determined by SPL, is all about the function of the machine. The lateral resolution, we can change the lateral resolution by moving the focus point. In the focus point, lateral resolution gonna be smaller, but the axial resolution, sonographer or ultrasound tech cannot do anything. It completely depends on the machine or system of the ultrasound machine. There are some synonyms of the axial resolution. Sometimes the same word axial resolution called longitudinal resolution, axial resolution, range resolution, radial resolution, and depth resolution. Whatever we call is the same meaning. In short form, call LARD. And how they calculate the axial resolution? Basically, machine itself calculate the axial resolution, but as a sonographer, how it calculate the axial resolution? It calculate on the basis of special pulse length, or SPL, divided by 2. It totally depends on the system function, because sonographer cannot do anything about the axial resolution, all about the machine setup, because we can't change the axial resolution. As I told you guys, how the what is the XPL? There's a distance of the pulse occupied from start the pulse and in of that same pulse, or it's on time. With time basis we call on time and off time. On time means when pulse is emitted, and off time means there is no pulse. It means it's a listening time. On time means the on time means is the activated time of the pulse, and off time is called listening or hearing times. SPL is the distance between the on time, or when the pulse is emitted. In other words, how SPL is calculated is the number of cycle. SPL is the number of cycle. How many cycles in a on time in a pulse. Lambda SPL is equal to number of cycle and lambda. Here lambda means number of cycle. Axial resolution. The structure within the same axis is shown in our display. If there is one structure shown in our display, means the SPL is bigger than two structures distance. It means let's talk about the image. There is a two structure which is parallel to each other, and there is the same main axis of the ultrasound beam. If SPL is shorter than two structure, our display gonna show there is two different structure. If the distance between these two structure is bigger than half of the SPL, then these two structure gonna be shown in the single image in our display. That's the reason axial resolution, how it works. The axial resolution is the ability to separate structure which is closely each other and having a same main axis. Let's talk about the temporal resolution. In simple understanding speaking, let's talk in a very simple way. Temporal resolution is image accuracy in time. Image accuracy in the time, or in other words, ability to show moving structure from instance to instant, or how the machine display the moving structure in real time. Temporal resolution, it depends on how many function is in use during ultrasound exam. It means how the sonographer use the machine. It means more function means worse the temporal resolution, and less function means better temporal resolution. Higher the frame rate, better the temporal resolution, and vice versa. What is temporal resolution? Temporal resolution is time specific resolution. It is the real time resolution, or it is the real time imaging. Temporal resolution is calculated on the basis of number of frame rate per second. For example, sometimes we see the blurry images, sometimes we see the slow motion imaging, That's the reason of temporal resolution. Is more frame rate, they're gonna be image gonna be clear and nice. Frame rate can measure the hertz. I already told you about it. Most important things operational parameter associated with the ultrasound movies is frame rate is the operational parameters, and the factor that determine the frame rate is speed of sound in medium and image depth. Or more the depth, less the temporal resolution. I mean the blurry the image is. The closer the superficial the organ, more clear, more deeper, less clear. Let's talk about this way. And the system setting affected frame rate is depth, image depth, and number of pulse per frame. Because we zoom per ultrasound, in ultrasound, there's a 2 to 3 cycle pulse wave. If there's a more pulse, gonna be less temporal resolution.
Ultrasound waves are not emitted continuously. They are formed by the diagnostic ultrasound systems sending out a short pulse of sound and waiting for the return echoes to be collected from the structures that are encountered along the path. And the depth of the structure is calculated by the time the return echoes take to reach the ultrasound system. So for echo, we used a phased array probe, which is a low frequency and a high resolution probe. So you can adjust your frequency, as they do have a range of frequency that can be adjusted on the probe. So if you want to see the superficial structures, you can increase your frequency, and if you want to analyze your deeper structures, you can decrease your frequency. And the few basic settings before you proceed to your echo: time gain compensation, setting your depth approximately, and please check your mechanical index and the thermal index. And the sector width has a major role in deciding your frame rate. So if you want to analyze a single structure, for example, an aortic valve or a mitral valve, you can decrease the sector size to the area that you want to visualize, which will help you increase your frame rate for a better temporal resolution. So as we talked earlier, the temporal resolution is the ability of ultrasound system to distinguish between events of rapidly moving structures during, for example, like during a cardiac cycle. Add on the axial and lateral resolution as explained by Ramesh earlier. So axial resolution can be improved by increasing the frequency, whereas the lateral resolution can be improved by adjusting the focal point near the structures that need to be visualized. Demonstration of correct positioning of focal point, which is critical to gain the best lateral resolution for a given transducer. Next topic: acquiring basic views of echocardiography by Dr. Mustafa Hassanin, consultant in emergency medicine with a special interest in POCUS from Leicester, UK.
Mustafa Hassanin. I'm an emergency medicine consultant with a special interest in POCUS. Today we'll talk about cardiac ultrasound, specifically acquiring basic cardiac views. So after this presentation, you'll be able to acquire basic cardiac views and able to identify different structures on each view. In echo or cardiac ultrasound, we use a phased array probe, which is a low frequency, high resolution probe with a small footprint, make it ideal to scan between ribs. The probe marker should be on the right side of the screen in a cardiac preset. Holding the probe is crucial for your comfort and the patient's comfort. You need to hold it like a pen and rest part of your hand gently on the patient's chest. If you hold it in a wrong way, it's unlikely that you will be able to obtain decent images, and you might cause discomfort to the patient. These are common terms that we use while doing any type of ultrasound, which is sliding, rocking, sweeping, fanning, compression, and rotation. We'll talk about 4 basic views, which are parasternal long axis view, parasternal short axis view, apical or 4-chamber view, and subcostal or subxiphoid view. To obtain a parasternal long axis view, you need to place the probe in the 3rd or 4th intercostal space immediately left to the sternum. The probe indicator should be pointing towards the patient's right shoulder. As the name implies, you are cutting the long axis of the heart. This is what you should be able to see. On your right is your left atrium, and then the flow goes through the mitral valve to the left ventricle on your left side, and through the aortic valve, through the aorta or the ventricular outflow tract, left ventricular outflow tract. On the top side of the picture, you can find the RVOT, which is the right ventricle or the right ventricular outflow tract. This is a picture from a simulator. Again, on the lower right, you will find the left atrium, and then the mitral valve. On your left side, you'll find the left ventricle, and that arrow there is the aortic valve, and this is the aorta, and the top side of the screen, you will find the right ventricle. This is a video of parasternal long axis view. On the right side, this is the left atrium, left ventricle, and this is the aorta. On the top side of the screen, this is the right ventricle. Again, this is another video of the parasternal long axis view, and you can see the left atrium, the mitral valve, left ventricle, and your aortic valve there, and then your right ventricle at the top side of the screen. Notice that you can get the aorta as well in the same view, and this can easily differentiate between pericardial and pleural effusions based on where the effusion from the aorta. And that's one more video. Your left atrium and your left ventricle and your aorta on the right side, and the right ventricle on the top side of the screen. Notice here that the gain needs adjustment, and that's why you can see very bright white color. This is a snapshot of the parasternal long axis view, and you can see the left atrium, the left ventricle on the left, and the left ventricular outflow tract, or your aorta on the right side, right ventricle on the top side of the screen, and your aorta down here. To get a good parasternal long axis view, you need to identify or be able to define three structures in that plane: the mitral valve, aortic valve, and the cardiac apex. Otherwise, you might lose crucial pathologies. And of course, clinical correlation is always needed when you're doing an echo. Rib shadow. So if you come across a rib shadow, you might angle, or you might want to angle the probe obliquely to avoid that rib shadow. Also try sliding the probe towards and away from the sternum in the same intercostal space if you can't get a decent view. If possible, you can ask the patient to lie in a left lateral position, and that will bring the heart towards the chest wall and help you getting a decent view. Moving to the second view, which is the parasternal short axis view. So from the same position as before, what you need to do is to rotate your probe 90 degrees clockwise. Your probe indicator should be pointing towards the patient's left shoulder. As in the illustration below, you can get three different cuts. You can get the aorta or the aortic valve, you can get the mitral valve, and you can get the apex. In a parasternal short axis view, you're slicing the heart at the short axis level. And at this level here, we've sliced the heart at the mid-papillary level. So that's why you can see the two papillary muscles on the right and lower left. And this black hole there is the left ventricle. On your left side, you will find the right ventricle, and between them is the septum. Sliding the probe towards the patient's right shoulder or left hip, or sometimes you can get away with just fanning the probe. You can get different cuts and different levels at the parasternal short axis. So you can get an apical view, you can get a papillary muscle level, you can get a mitral valve level, which is called the fish mouth view. You can get a basal level or an aortic valve view, which is the famous inverted Mercedes sign view. So this is a picture of the mid-papillary muscle level. So you've got the left ventricle, which is the circle that you can see there, and then you've got fleshy structures on the right and the left of that circle, which are the papillary muscles. So this is a video of the parasternal short axis view at the papillary muscle level, and you can see in this view how the left ventricle is trying to contract. In this particular video, in the parasternal short axis view, you can get another view, which is the mitral valve or the fish mouth view. You can see on the right side that the mitral valve will be open during diastole and closed during systole. This is a video of the mitral valve or the fish mouth view. You can also get the aortic valve level or the inverted Mercedes sign view, as you can see here in that simulator picture. This is the aortic valve and you can see the Mercedes sign. So to get a good parasternal short axis view, you can more or less follow the same tips for the parasternal long axis view. So angle the probe obliquely if you find a rib shadow, or try sliding the probe towards and away from the sternum in the same intercostal space. And if the patient is well enough, ask him or her to sit forward or to lie in a left lateral position. Now moving to the apical view or the four-chamber view, you need to place the probe at T4-5 level or the nipple line, or feel where the point of maximal impulse is, and that's simply by placing your hand and see where the heart beats most. Your probe indicator needs to be pointing towards the patient's left shoulder, and this is what you will see in the apical view. This is a four-chamber, so on your lower right, this is your left atrium, upper right, this is the left ventricle, upper left, this is the right ventricle, and lower left, this is the right atrium. You can always tell the difference between the left ventricle and the right ventricle by the thickness of the myocardium. Remember that the left ventricle is muscular, and hence the myocardium is thicker than the right ventricle. Also remember that the right ventricular size is about half or 0.7 of the left ventricular size. To make it easy for you to remember, if the right ventricle is the same size of the left ventricle, you need to think that something is wrong. One of the most common pathologies that we see that can cause right ventricular enlargement is PE, or pulmonary embolism. This is a video of the apical or four-chamber view. On the right lower side you've got the left atrium, right upper you've got the left ventricle. You can see the mitral valve there, and then on the left lower side of the screen you can see the right atrium, and then left upper you can see the right ventricle, and you can see that it's about half the size of the left ventricle and not as thick myocardium there as in the left ventricle. Another video of the apical view, and you can see here that the left ventricle on the upper right side of the screen is massive and dilated and almost taking the whole of the screen, and that's of course not normal. And that's why in this particular view it couldn't get everything, and by everything I mean the apex of the heart, but you can see still the four chambers, which is the right atrium on the left lower, right ventricle in the upper left of the screen, and left ventricle on the upper right side of the screen, and the left atrium on the lower right side of the screen. It can be tricky sometimes to acquire an apical view, so you can always slide the probe around the point of maximal impulse, and again, if the patient is well enough, ask him or her to lie in a left lateral position or sit forwards, and by that way you can bring the heart nearer to the chest wall, and hence getting better views. Moving to the last view, which is the subcostal or subxiphoid view. place the probe in the subxiphoid position, aiming towards the left shoulder. Try and make the probe as flat as possible to the abdominal wall. Usually it's 10 to 15 degrees, but it's acceptable to make it totally flat. The probe indicator should be pointing towards the patient's left side. This is the view that you will see in the subcostal view. And basically you will be seeing a 4-chamber view, but a bit rotated. And notice that you're using the liver as an acoustic window. So again, here the LV is your left ventricle, LA is your left atrium, RV is your right ventricle, and RA is your right atrium. And the liver is on the left side of your view. Here you can see a video of a subcostal view. On the right side you've got the left ventricle, and on the left lower side you've got your left atrium, and then the right ventricle and right atrium is above them. In the subcostal view, if you rotate your probe 90 degrees anti-clockwise, you might be able to get this view, which is the view of the IVC going into the right atrium. And this is the kind of the start of the right atrium on the right side of the screen, which is the bit balloon there. You can always use this view to assess the intravascular status and whether the patient is intravascularly depleted or overloaded. And of course, clinical correlation is crucial, and you can't use ultrasound or echo alone to determine this condition. To get a decent subcostal views, you need to adjust the depth, and you might need to flatten the probe as we mentioned on the abdominal wall. You can always slide the probe towards the right side to make use of the liver as an acoustic shadow or acoustic window. If possible, you can ask the patient to bend his or her knees to relax the abdominal wall muscles. Remember that although theoretical knowledge is important, practicing is very crucial when it comes to using ultrasound. So at the end of this presentation, I hope that helps, and thank you very much for listening.
Thank you, Dr. Hassanin, for a detailed presentation in acquiring cardiac views. The next topic, Identifying Pathology from Basic Views, by Dr. Mathur, Assistant Professor of Pediatrics, New Delhi, India.
Hello everyone. I am here now to connect the dots. We will now build upon our knowledge of ultrasound physics and echocardiography views to see a few pathological echocardiograms. We must know that it is extremely important to perform a comprehensive echocardiographic examination. This involves assessment of all of the following: the left ventricle, including its wall thickness, chamber size, systolic function, ejection fraction; the right ventricle, its size and function; the atria, their sizes; the valves; the inferior vena cava; the aorta; shunts if any; intracardiac masses if any; and the pericardium. The detailed discussion of valvular and shunt lesions would be done in future webinars after we have discussed color and Doppler echocardiography in detail. Determination of the left ventricular mass has important clinical implications, especially in hypertensive patients. The presence of hypertrophy has been associated with worsened outcomes, and its regression has been a goal of therapy. The determination of left ventricular mass can be done by assessing the wall thickness of the left ventricle. A good way is to see the wall thickness in relation to the left ventricular cavity. This should be done using multiple views like the parasternal long axis view, the parasternal short axis view, and the apical four-chamber view. This echo shows increased left ventricular wall thicknesses in all the views. Here we see the thickness in the walls. And we also see that the cavity size is significantly reduced. This schematic representation of the parasternal long axis view shows the different measurements. We can perform linear measurements of the posterior left ventricular wall and the interventricular septum and correlate with standards to diagnose left ventricular hypertrophy. A simple rule of the thumb is in the upper normal limit is 1 centimeters for posterior wall and the interventricular septum in adult males. One additional index of hypertrophy is relative wall thickness, which is defined as the posterior wall thickness plus the interventricular septum thickness divided by the left ventricular internal dimension in diastole. This relative wall thickness, if is more than 42%, it can be used as a threshold of pathological left ventricular hypertrophy. When assessing for left ventricular function, it is of clinical importance to assess the left ventricle outflow tract and the interventricular septum. This echo shows a sigmoid septum causing dynamic left ventricular outflow tract obstruction. It also shows a systolic anterior motion of the mitral valve. This is seen here in the parasternal long axis view. We can also see a small pericardial effusion. So in such patients, if they present in hypotension, then we would give fluids and we would not give vasopressors to these patients. Although a Doppler is not being discussed today, but you can see a turbulent flow through the left ventricular outflow tract. This is an echo of a patient who presented with congestive heart failure, with shortness of breath and exercise intolerance. Even though the left ventricular mass appears normal, what is striking here is the left ventricular cavity, which is dilated. The normal shape of the left ventricle is referred to as the bullet shape or an elongated ellipse. However, as a consequence of dilation and systolic dysfunction, the left ventricle takes a more spherical geometry. A simple rule of thumb for cutoffs of the left ventricular internal diameter in diastole for males is more than 6 centimeters, suggesting mild dilation, and more than 7 centimeters, suggesting severe dilation. Normally, the long axis dimension of the left ventricle exceeds the short axis diameter with a ratio of 1.6:1 or greater. However, with progressive dilation, the minor axis increases disproportionately and the ratio of long to minor access decreases. This ratio, also called as the sphericity index, if is less than 1.5:1, it implies dilation and pathological remodeling. Dilation also leads to apical and lateral shifting or displacement of the papillary muscles. This effectively reduces the length of the mitral apparatus and results in mitral regurgitation. One of the most commonly used surrogates in assessing the left ventricular systolic function is the measurement of the left ventricular ejection fraction. The qualitative assessment for the ejection fraction involves assessing the movement of the left ventricular walls and assessing the movement of the mitral valve. When assessing for the left ventricular walls, use the parasternal long axis view, the parasternal short axis view, and the apical four-chamber view. Then you should assess for radial and longitudinal contractility. The decrease in the long axis dimension would mean the longitudinal contractility, and the movement with respect to this short axis would mean the radial contractility. You need to see whether the walls are pulling in evenly and are they pulling in too much or not enough. The magnitude of opening of the mitral valve correlates with the volume and transmitral flow, and in the absence of any significant mitral regurgitation, it correlates directly with the left ventricular stroke volume. These qualitative assessment techniques are operator dependent, and the more you do, the more accurate you will become. The same features have also been standardized for quantitative measurements. In this schematic representation of the parasternal long axis view, fractional shortening of the left ventricle can be calculated. This is indicative of the ejection fraction. The fractional shortening is calculated as the left ventricular internal dimension in diastole minus the left ventricle internal dimension in systole divided by the left ventricular internal dimension in diastole. Well, the left ventricle internal dimension in diastole is measured in one frame before the opening of the aortic valve, and the left ventricle internal dimension in systole is measured on the closure of the aortic valve. A simple rule of thumb is that if the fractional shortening is more than 25%, it is considered as normal, and if it is less than 15%, it is considered as severely abnormal. Another measurement is the measurement of the tip of the anterior mitral leaflet, which is called as the E point during the ventricular diastole. Now, this distance between the tip of the anterior mitral leaflet and the interventricular septum is called as the E point septal separation. Normally, the mitral valve E point is within 6 millimeters of the left side of the ventricular septum. In the presence of decreased ejection fraction, this distance increases. Currently, the most common method for determining ventricular volumes is the Simpson rule, or the rule of discs. For our basic discussion today, however, we limit ourselves to the linear measurements only. We can discuss the details in another webinar, which would include measurements and calculations. I would also like to share a tip here. As the linear measurements are only along a single line, this may either underestimate the severity of global dysfunction if only a normal region is interrogated, or overestimate the abnormality if the measured area has regional dysfunction. So, one must always have an interpretation based on both the qualitative and the quantitative assessment. A 65-year-old female patient presented with abrupt onset of chest pain, which was accompanied by dyspnea and evidence of congestive heart failure. The electrocardiogram revealed deep symmetric T-wave inversion in the anterior precordium. Enzyme elevation was mild. There was also a history of the sudden death of her husband in a road traffic accident 2 weeks ago. This is her echo. Let us first see. Well, this echo reveals a marked dilation and ballooning of the left ventricular apical segment. Even though the septum of the and the anterior leaflet almost are meeting in the parasternal long axis view, this does not reflect a global left ventricular function. The basal septum is hyperdynamic here, so focusing only on the E-point septal separation data alone would give an erroneous impression of the overall function. In systole, this results in a light bulb shaped left ventricle, which resembles the Japanese octopus trap, and hence the name Takotsubo cardiomyopathy, also called as the Takotsubo syndrome, broken heart syndrome, stress cardiomyopathy, or the apical ballooning syndrome. A qualitative assessment of the right ventricle is a routine part of echocardiography. Normally, right ventricular size is approximately 2/3 that of the left ventricle. This estimate is based on a comparison of the relative sizes of the two ventricles from multiple views. An additional approach to the right ventricular systolic function involves the quantitative assessment of the tricuspid valve annular motion during systole, or the TAPSE, that is the tricuspid annular plane systolic excursion, the distance that this plane would move during the systole towards the apex. This can be recorded from the apical four-chamber view. The tricuspid annular motion during systole is normally between 17 and 28 millimeters. A value less than 17 millimeters is suggestive of right ventricular systolic dysfunction. This echo shows a dilated right ventricular outflow tract in the parasternal long axis view, a hyperdynamic left ventricle, a paradoxical movement of the interventricular septum, and poor tricuspid annular plane systolic excursion. Regional patterns of the right ventricle also need to be seen for. Here we can see what is referred to as the McConnell's sign, that is akinesia of the right ventricular mid-free wall and hypercontractility of the apical wall. It is highly suggestive of acute massive pulmonary embolism. Now in this parasternal short axis view, we can see what is called as the D sign. The left ventricle appears as a D-shaped structure instead of the circular as a result of the right ventricle overload causing a shift of the septum towards the left side of the heart. The D sign can result due to both right ventricular pressure or volume overload. We quantify this by the eccentricity index, which is again beyond today's limited basic discussion. The left atrium serves as a reservoir for blood draining the pulmonary veins during the ventricular systole and as a conduit for that blood during early diastole. In late diastole, the left atrium becomes a muscular pump to complete the process of left ventricular filling. Thus, changes in the left atrium dimensions and volumes mirror the continuous process of filling and emptying. Bowing of the atrial septum into the right atrial cavity indicates left atrial dilation and or elevation of the left atrial pressures, which is most easily appreciated using this apical four-chamber view. Another indirect measure of left atrial size seen in the parasternal long axis view is the ratio of the aortic root diameter to the short axis of the left atrium. In normal subjects, the ratio of these two dimensions is approximately 1.1:1. A significant change in this ratio is a useful visual indicator of an abnormal left atrial size. This echo shows bilateral atrial dilation, aneurysmal interatrial septum, left ventricular hypertrophy, a small pericardial effusion, and we would need some lung windows to look for the pulmonary edema. The normal thoracic aorta consists of 6 segments. These are the annulus, the sinuses of Valsalva, the sinotubular junction, the ascending tubular aorta, the arch of aorta, and the descending thoracic aorta. The aortic annulus is defined as the junction of the proximal ascending aorta with the left ventricular outflow tract. It is part of the fibrous skeleton of the heart and is contiguous with the anterior mitral leaflet and the perimembranous septum. It is relatively resistant to dilation and can be used to index the remaining aortic sizes. The measurement should be made perpendicular to the long axis of the direction of the flow of blood. This parasternal long axis view shows dilation of the ascending aorta. Note here that the annular dimensions are relatively preserved. An elderly, unwell hypertensive patient presented with chest pain radiating to the back. This is the echo which was done. In this echo, we are able to see an intimal flap in the proximal aorta. When an intimal flap is confidently detected on transthoracic imaging, the diagnosis of an aortic dissection can be confidently established. However, other imaging techniques such as the transesophageal echocardiography, a CT, or an MRI are necessary to fully characterize its extent. In this echo, we see a mass in the left atrial chamber. A myxoma is the most common cardiac tumor, accounting for 20 to 30% of intracardiac tumors. Its most common location is the left atrium, with the attachment site in the interatrial septum. The tumor can obstruct the atrioventricular valve and produce a tumor plop that is heard on auscultation after the second heart sound. This echo also shows a mass in the right atrium. This mobile mass seen in the right atrium is a clot in transit. Thrombi from the lower extremity deep veins must go through the right atrium to reach the pulmonary circulation. They are mobile, have a characteristic popcorn or a snake-like appearance, and almost always are associated with pulmonary embolisms. Let us come to the next thing, that is the pericardium. The pericardial effusions tend to be most prominent in the more dependent areas. Therefore, in patients in supine position, it appears maximally in the posterior atrioventricular groove, seen in the parasternal long axis view. Using additional views like the parasternal short axis view, the apical view, and the subcostal views, the circumferential extent of an effusion can be reliably determined. An important tip here is that the pericardial reflection is typically anterior to the descending thoracic aorta, and therefore fluid appearing posterior to the descending thoracic aorta is more likely to be pleural, whereas fluid appearing anterior to the aorta is more likely to be pericardial. In this echo, we can see the descending thoracic aorta and a small pericardial effusion which is anterior to this descending aorta. Minimal pericardial effusion represents the normal amount of pericardial fluid in a disease-free state. It is visualized as a small echo-free space in the posterior AV groove only in systole when the heart is pulled away from the pericardium. A small effusion is defined as one resulting in as much as 1 centimeter of posterior echo-free space. A moderate effusion is defined as 1 to 2 centimeters of echo-free space. Large effusions as more than 2 centimeters of maximal separation. And very large effusions, in them the heart may swing within the pericardial space. So these definitions may vary from place to place, and in clinical practice, semi-quantitative description of the pericardial fluid size is a standard practice. In this echo, we see a very large pericardial effusion, and we see the heart is swinging in this fluid-filled cavity. The echocardiographic findings can also suggest the presence of hemodynamic abnormalities in patients with cardiac tamponade. A diastolic right ventricular collapse and an exaggerated right atrial collapse during the ventricular diastole are well validated as evidence that intrapericardial pressures exceed the cardiac filling pressures. In this echo clip, in the apical four-chamber view, we see right atrial collapse during ventricular diastole, and in this subcostal view also, we see the right ventricle diastolic collapse. The last part of this clip is showing a tamponade through the left costophrenic angle. Now this echo shows ascites and pleural effusion in the subcostal view. A very small pericardial effusion can also be seen in this echo. Now here you can look at the falciform ligament floating from the diaphragm. This brings me to the end of today's presentation. Thanks a lot everyone for a patient listening. I'm always open for your questions and suggestions. Have a wonderful day.
Small correction on the tamponade pathology. It's systolic collapse of right atrium and diastolic collapse of left ventricle. and not as described before. Apologies. Thank you, Dr. Mathur, for detailed explanation of basic pathology in echocardiography. And also I would like to thank Life in Fastlane Library for some of the clips in the videos. The next topic is simulator time. Initially we have planned for a live session from the simulation lab, but since I am the moderator for this webinar, I have to be in front of the computer with a good internet system. So we are playing the recorded videos from the simulator now. The basic echo views: parasternal long axis, parasternal short axis, apical views, and subcostal views.
Third, for general consciousness, probe marker towards the right shoulder. Rotate the probe, parasternal short axis, with apical fluid surrounding. Just provide anything. IVC. Just rotate the probe.
Parasternal long axis with the probe marker pointing towards the right shoulder. So in the parasternal long axis, starting from the top, right ventricular outflow tract, left ventricle, left atrium, mitral valve, and the aortic valve. Here, the descending aorta is also focused in the parasternal long axis. Descending aorta is an important landmark to distinguish pericardial effusion from pleural effusion. Any fluid above the descending aorta is considered as pericardial effusion, and any fluid below the descending aorta is pleural effusion. You can also visualize any dilatation or aneurysmal descending thoracic aorta in this view, or any dissection flap can be looked for. And this is the E-point septal separation that Dr. Mathur was speaking earlier. You can calculate the distance between the septal wall and the mitral valve. You can also use M-mode to calculate the EPSS, which is a rough guide for your ejection fraction, but should not be used alone without visualizing your entire left ventricle. Focusing on the base of the heart, again your left atrium, left ventricle outflow tract, aortic valve, root of aorta, and the ascending aorta. Evaluating the apex of the left ventricle, you can look for the contractility, any dilatation, or any apical thrombus. Right ventricular inlet, right atrium opening into the right ventricle through the tricuspid valve, Tilting the tail of the probe towards the patient's head from your parasternal long axis will get you into this view. Tilting the probe towards the patient's tail, the tail of the probe towards the patient's feet will bring this view, which is the right ventricular outflow tract and the pulmonary valve. Demonstrating the RV inlet and outflow tract from the parasternal long axis view. Parasternal short axis. Rotate the probe marker towards the patient's left shoulder to get this parasternal short axis view. This is the mid-papillary level, and fanning the probe towards the right shoulder of the patient without moving the probe itself will get you to the fish mouth view of the mitral valve and aortic valve. The inverted Mercedes-Benz sign of the aortic valve. So this view you can assess if the aortic valve is bicuspid or a tricuspid. Rocking the probe at the aortic valve level superiorly brings the pulmonary valve and the right ventricular outflow tract into view. The same aortic valve level, rocking the probe superiorly, you can see the right atrium, right ventricle, and right ventricular outflow tract with the pulmonary valve. Demonstrating pathology from parasternal short axis view, assess the contractility of the valves of the left ventricle. As you fan towards the apex, you see the contractility is almost nil and an apical thrombus coming into the view. The four-chamber view, probe marker towards the left side of the patient. Left ventricle, left atrium, right atrium, and right ventricle. The radial contractility of the RV is not seen well here, and placing the M mode cursor at here, you can calculate TAPSE, which is the tricuspid annular systolic excursion. So tilting the probe anteriorly brings 5-chamber view. You can calculate left ventricular outflow tract velocity time integral by placing your pulse wave Doppler here, and flow through the aortic valve by placing your continuous wave Doppler here. This is an example of foreshortened view. When you encounter this, try to move one intercostal space below. This is an off-axis view of the 4-chamber view. So you could be very medial. Correct this off-axis by gently rocking and sliding towards the left side of the patient. A 2-chamber view. Rotating your probe so that your probe marker facing the left shoulder brings the apical 2-chamber into view. Rotating the probe from the 4-chamber view to get the 2-chamber view. And this is the 3-chamber view. You can calculate the VTI, assess the aortic valve function in the 3-chamber view as well as your 5-chamber view. So, what are the struggles that we face getting a 4-chamber view? The rib shadows, the lung shadows, it's not a easy view to get, especially for novices. Try to get any portion of heart into your focus first. Once you start visualizing a portion of the heart like here, try to do some gentle adjustments to get the full view of your heart. Subcostal views. The probe marker towards the patient's left. You're looking at the heart through the liver acoustic window. You will see the right ventricle resting just above the diaphragm. This view is best for assessing pericardial effusions, and also a good view to be used in end of life support when a CPR is ongoing on a patient. You can use a subcostal view without interrupting your CPR. Bringing the probe marker towards the ceiling in your subcostal view can help you visualize parasternal short axis from the subcostal view. You can do all the measurements that you do on a parasternal short axis here with this view. You can assess the relative size of right ventricle with the left ventricle. You can assess the septum movement and relative chamber sizes in the subcostal view as well, especially those with very poor parasternal views. IVC. You identify IVC by non-pulsatile structure going through the liver, emptying into the right atrium, and you see a hepatic vein draining into the IVC. The diameter of IVC and collapsibility is measured just distal to the hepatic vein and not proximal, because if you measure proximally, you will be measuring the right atrium rather than the IVC diameter. Tilting the tail of the probe towards the patient's right from your IVC view brings the aorta brings us to the end of today's webinar. Thank you all for participating, and once again I thank all our speakers for their valuable time.